Welcome back to our educational series on Bertolotti syndrome. In the last episode, we discussed the underlying anatomy that leads to Bertolotti syndrome. In this episode, we'll talk about the diagnostic protocol for this condition. As with all videos in this series, the information shown in this video is based on peer-reviewed research and published clinical data. For every information that is shown on screen, there will be a source as well as the link to that research paper in the description box below the like button. So with that out of the way, let's dig into the diagnostic protocol for Bertolotti syndrome. Imagine having back pain that just won't quit. It's not the I lifted a heavy box and now I don't feel good kind of pain, but rather I've had this pain lingering for years and just doesn't seem to go away. So that is the kind of pain that a lot of people with Bertolotti syndrome suffer. The pain from Bertolotti syndrome typically happens fairly early on. Based on a recent study by Jenkins and his colleagues, they have shown that the diagnosis for Bertolotti syndrome happens at an average age of 49. However, other research has shown that some people may have symptoms develop as early as mid to late teens. Now you might be wondering why there is such a big difference between when the symptoms develop and when the average diagnosis happens. As we discussed in our last episode, about 20% of the population, that is 1 in 5 people, may have lumbosacral transitional vertebra. However, not all of them will develop symptoms. Therefore, it is very easy for the diagnosis to not happen early on. So, you might be wondering then, what does the pain feel like? It is often described as a mechanical pain. That is, it is triggered by specific movements. Some of the movements that actually cause this pain is bending or flexion, sitting for prolonged periods of time, as well as twisting motions. The tricky part with Bertolotti syndrome is that the symptoms may not be uniform for everyone. Some people will have just pain in their lower back and nowhere else, whereas others can have radicular pain, as in radiating nerve pain down the leg, similar to sciatica, whereas others can have other symptoms. Furthermore, some patients may have other issues besides Bertolotti syndrome, such as a disc tear, a disc bulge, or herniation, as well as other congenital conditions such as EDS. That chronic aching lower back pain that just seems to persist for a long time seems to be a common symptom across a majority of Bertolotti syndrome patients. Learning about the patient history is just one piece of the entire puzzle. However, physicians need more than patient history. This brings us to the second step in the diagnostic protocol, which is conducting a physical exam. Dr. Colin Haynes explains what he looks for in a physical exam in our last video, as shown in this clip.
The history is critical, examination is paramount. As you mentioned, it's making sure there's nothing else going on. So making sure it doesn't seem like a disc, an SI joint, a facet joint. There's a lot of overlap between that and Bertolotti's, but really tenderness directly over the area where you have that extra bone that's rubbing on itself is something I use when I manually press on that area.
You would think having an enlarged transverse process that is rubbing against your pelvis would be very hard to miss. Well, not exactly. The problem starts with a standard x-ray. When you take a typical x-ray for your lower back, using the AP view where you're facing towards the x-ray machine, the natural curve of your lower back and pelvis leads to the occlusion of that lumbar segment, and it is not easy to clearly see that lower lumbar segment in the transverse processes. This means that false joint or pseudoarticulation is literally hidden behind the other structures. To address this issue, the gold standard for imaging that lumbosacral junction is called the Ferguson view. The way the Ferguson view is actually taken is the X-ray beam is tilted upwards by 30 degrees so that it can clearly see that lumbosacral junction, i.e. the last lumbar segment in your sacrum. As you can see in the representative images, the Ferguson view allows you to clearly see the last lumbar segment and the transverse processes, as well as the pelvis, compared to the normal view where that segment is actually partially occluded. Methods from the future here, just a quick thing. You can see that both in the AP view as well as the Ferguson view that the LSTV is very clear, but the Ferguson view does allow you to see how that joint actually connects with the sacrum as well as the iliac crest. The AP view does show you whether or not you have LSTV, but it's just very hard to tell which type you are. Alrighty, back to the video. Another useful imaging technique is an MRI. The MRI is used to evaluate surrounding tissues besides the bone. This allows your physician to assess whether or not you have other conditions or other issues besides a lumbosacral transitional vertebra. For example, you could have a disc tear or a disc herniation, or you may have some nerve root compression or other conditions that are easily identified using an MRI. Finally, physicians also utilize CT scans. However, CT scans are not the best tool at the early stages of the diagnosis, mainly because it exposes the patient to excessive radiation compared to an X-ray. And secondly, they can be somewhat costly. As we discussed in the last episode, just because you have LSTV does not mean you have Bertolotti syndrome. Remember, 1 in 5 people do have LSTV. So, how do we know that the LSTV is the source of back pain? This leads us to the final step in the diagnostic protocol, which is performing a diagnostic injection. Under the guidance of a live X-ray imaging called a fluoroscope, the physician places a tiny needle into that false joint and injects a small amount of numbing medicine, such as lidocaine, into that joint. If your pain is significantly reduced after this injection, this means that that joint is the source of your pain. However, if you do not experience reduction in your pain symptoms, then it could be that you have other conditions that are contributing to the issue and that the LSTV is an innocent bystander. In summary, the diagnostic protocol for Bertolotti syndrome is made up of 4 crucial steps. First is to assess the patient history. Second, a physician conducts a thorough physical exam. Third is to perform diagnostic imaging using X-rays, MRI, and CT scans. And lastly is to administer the diagnostic injection to conclusively determine whether or not that LSTV is the source of your pain. Getting a diagnosis is a huge step. Some people have gone over a decade before realizing the cause of their pain. Once you have been diagnosed with Bertolotti syndrome, the question remains, what's next? In subsequent episodes, we will cover the different treatment options for Bertolotti syndrome, as well as explore other conditions that typically are associated with Bertolotti syndrome. If you find this video helpful, please consider liking and sharing this video. This is the best way you can help us make more videos like this in the future. As always, you can find more information on Bertolotti syndrome as well as other useful resources such as a directory to physicians that are knowledgeable in Bertolotti syndrome on our website at aboutbertolottis.org. Finally, you can find all the information that is shared in this video in the description box below, as well as the links to the research papers that have been used to make this video. Until then, stay curious. Thanks for watching.